This one young lady with a distant family history of mental illness, and she became obsessed about getting mentally ill and having to go to a mental hospital. So she made an appointment with the director of a local psychiatric hospital, and he asked him the following question. He said, "How do you know when somebody is sick enough to be hospitalized versus being treated as an outpatient?" And the director took her into a room, and in that room there was a bathtub full of water, a bucket, a cup, and a spoon. So he told her that in order to find out if the patient needed to be hospitalized, we bring the patient here and we ask them to empty the bathtub. So the woman thought for about a minute, and then she says, "Oh, I know, the healthy individual will use the bucket, right?" The director looked at her and says, "Actually, the healthy individuals would pull the plug. Would you like to have a bed by the window?" So I was thinking to implement that at metro admissions, but I don't know how it will work. Anyway, so let's talk about the mood stabilizers and see why the FDA thinks that there's no such thing as mood stabilizers. And let's look at whether there are some medications that can be called mood destabilizers. But here's a trivia question. Which soft drink used to contain lithium citrate when it was originally formulated in 1929? So it's the 7-Up. It was called Big Label Lithiated Lemon Lime Soda. So for 20 years it contained lithium, and then in 1948 lithium was removed. Interesting. But it's also interesting that there was that each one of us, we have small amounts of lithium in our bodies, and we get that from waters and from drinking water and from vegetables. And in January of this year, there was an interesting study published in the European Journal of Nutrition. It's a Japanese study that they were looking at different areas of Japan, different parts, when the water contained high amount of lithium, in areas where the water did not contain high amount of lithium, or almost no lithium at all. So they found two things, that in the area where water contained lithium, people lived longer. The lifespan was longer, and also there were fewer suicides. So interesting. And then the Germans did the same study in Germany and got the same results. Very interesting, and it has interesting ramifications. But let's go and see why mood and reason are different, and where do we get this idea that mood and reason are different areas. So we get this from Plato, and he described logos or reason, and he also described thumos or mood. So from logos we derive the words such as logic, and from thumos we derive words such as euthymic, dysthymic, and so forth. And Plato believed that logos should be in charge of thumos, or thumos should be under the control of logos. Now, if we fast forward to Kraepelin, Kraepelin was interested in classifying diseases, and he was doing statistics and looked at different symptoms and tried to put them in syndromes and diseases. So he described psychosis or schizophrenia. He didn't call it schizophrenia, it was called later, but he called it dementia praecox, and then cyclic psychosis or bipolar disorder. And he thought they were different entities. So he thought that schizophrenia is a chronic illness in which patient gets worse and worse in time. And he thought of bipolar disorder as a condition in which there is the episodes, and then there's a restitutio integral, or the patient comes back to normal in between these episodes. And our thinking of schizophrenia and bipolar disorder is still influenced by Kraepelin. That may be the reason why we overdiagnose bipolar disorder in order to give patients more hope, you know, and if it's an affective component, then we think of it in terms of a better prognosis. Now, this distinction that was seen by Plato and by Kraepelin seems to match the physiology of the prefrontal cortex. So what we have here is the dorsolateral prefrontal cortex, is this area here, that has to do with the cognitive functioning, with logic. So that would be Plato's logos. And then you have the ventromedial prefrontal cortex, this brown thing here, that has to do with emotional processing and mood. And then this other area, the anterior cingulate cortex, ACC here, it has to do with selective attention. So lesions of tumors here in this area would cause inability to sustain attention. And this area is also involved in ADHD, we know that now. And then the orbitofrontal cortex here, right, this blue thing, it has to do, lesions there cause obsessions and compulsions. And by the way, in pandas, the pediatric autoimmune disease, the autoimmune lesions are in that area. So this division between mood and reason seems to be endorsed by the physiology. Now, these areas of the brain are connected with each other and with the subcortical areas by circuits. So we have circuits and so forth. And it is believed that the emotion is regulated by this corticostriatal cortical circuit. So it's basically a loop that starts from the anterior cingulate cortex, goes into the nucleus accumbens here, and then the thalamus, and back to the ACC, or anterior cingulate cortex. And excessive mood fluctuations reflect inefficient information processing in this circuit. Now, when we give medications, how do we influence these things? Well, the circuits are modulated by neurotransmitters. So various circuits of the brain are modulated by neurotransmitters. Some of them we know, some of them we don't know, some of them we know only partially. But the ones that we care about are the monoamines, the dopamine, norepinephrine, and serotonin. And some of these circuits are modulated by one or all three of these monoamines. So this is the elevated irritable mood circuits, which is modulated by the ventromedial prefrontal cortex, amygdala, orbitofrontal cortex. And so those are the circuits, and they are modulated by serotonin, norepinephrine, and dopamine. Grandiosity and flight of ideas and racing thoughts, they involve the same circuits that are involved in psychosis, which basically involve the nucleus accumbens. And this is probably why many medications that are antipsychotic, they also work in manias. The sleep circuits involve the thalamus, hypothalamus, basal forebrain, and the prefrontal cortex. And they are also modulated by all three monoamines. Distractibility circuits start from the dorsolateral prefrontal cortex and go to the striatum, and they are modulated only by norepinephrine and dopamine. Now, this is about the mood stabilizers. So basically, the FDA says there's no such thing as a mood stabilizer, and we'll see why. But we psychiatrists, we talk about them. You know, we think they exist. And the vet says, I think I'm bipolar. By the way, there's no bipolar vets, they all live in South Pole. So what is a mood stabilizer? Well, originally a mood stabilizer was something that worked from above or from the manifold, something like lithium, that would prevent manias. But more recently, the concept of mood stabilizers was broadened as to include, something that acts like lithium, anticonvulsant medications, atypical antipsychotics that are used in the treatment of bipolar disorder and so forth. So what is the ideal mood stabilizer? Well, an ideal mood stabilizer would have to work in both acute and maintenance phase. And in the acute phase, would have to work on mania and depression. So at the present time, no single drug meets this criteria. So we have drugs that are efficacious for different phases of bipolar illness. So for this reason, we use combinations. So some agents are more mania-minded, they treat from above, and other agents are more depression-minded, so they treat from below. So when we talk about treating from above, more like lithium, when we talk about treating from below, more like maybe lamotrigine or atypical antipsychotics. Now, these are the FDA-approved drugs for mania and the FDA-approved drugs for maintenance therapy of bipolar disorder. The following drugs have the FDA approval for mania. And here is aripiprazole, carbamazepine ER, chlorpromazine, vivaporex ER, lithium, olanzapine, quetiapine, risperidone, and ziprasidone. Now, please note that carbamazepine, regular carbamazepine, or even trileptal are not included here. Only carbamazepine ER. Regular Tegretol does not have indication for bipolar disorder, for acute or for maintenance. We use it, but it doesn't have the FDA approval. And please note that the Vivaporex ER has the indication for acute maintenance, but not the regular level. Now, the following drugs are approved for maintenance: aripiprazole, lithium, regular Depakote, Lamictal, and the combination of olanzapine, fluoxetine, or Symbiox. So olanzapine by itself does not have the indication for maintenance, only the combination, according to the FDA. Now, quetiapine has the FDA approval for the treatment of both acute phase of bipolar mania, bipolar depression, but not for the maintenance phase. If Seroquel would have the approval for the maintenance phase, it would be an ideal mood stabilizer, but it's not. So this is the ideal mood stabilizer. This doctor says, I'm going to recommend a Thorazine Ritalin cocktail just to see what the heck happens. One lower, one down, and one another. Now these are the medication groups that are used for affective stabilization. We know them already: lithium, anticoagulants, atypical antipsychotics, and other agents. Now, other agents, we have here memantine, we have amantadine, we have ketamine, we have calcium channel blockers, the L-type. Those are the calcium channel blockers that are used in medicine, like verapamil and nifedipine. So they are different from calcium channel blockers that anti-epileptic medication work on. And then we have riluzole. Riluzole is a medication that has the FDA approval for amyotrophic lateral sclerosis, but it's being used for bipolar disorder. It's just very expensive, so people cannot afford it. Lithium in acute mania, efficacy 49 to 79%. It takes a long time to have the onset of action, up to 3 weeks. And predictors of response: classic mania, fewer episodes, or initial manic episodes. Those respond the best to lithium. Tolerability, cognitive dulling, tremor, renal failure, polyuria, GI upset, thyroid suppression, weight gain, sick sinus syndrome sometimes. Now, drug-drug interaction, this is a little bit more interesting because lithium used with antipsychotics may increase lithium toxicity. And lithium used with Wellbutrin may increase seizure risk. Technical with lithium, sometimes neurotoxicity. And we know that diuretics increase lithium level. If iodine salts are used for hypothyroidism, they may not work with lithium. Neuromuscular blocker with lithium causes respiratory depression. So why this is important is for ECT, that they have to discontinue ECT. Non-steroidals increase the lithium level. Don't forget that lithium is a serotonergic drug, so in combination with SSRI may cause the serotonin syndrome or serotonergic syndrome. Theophylline decreases lithium levels. Urinary alkalizers decrease lithium levels. And verapamil can do both increase or decrease levels. Now the mechanism of action of lithium is still debated. You know, there's probably 3 or 4 ways the lithium works, but we don't know exactly how it works. So it works on the second messengers. Well, we always study about second messengers for the exams, and then we forget what they are. But it's actually simple. Let's ask this question: what are the first messengers? Well, the first messenger is the neurotransmitter itself. You know, the dopamine, serotonin, norepinephrine. So second messengers is released in the postsynaptic neuron, and it can be, depending on the pathway, it can be the C protein, or it can be calcium. For the so-called metabotropic receptors, those are receptors that are not channeled, that they don't have a hole in them. For them, the second messenger is the C protein, and for the channel receptors, the second messenger is calcium. So let's look at this graph. So first messengers are the neurotransmitters themselves. Second messenger is the C protein here in metabotropic receptors, or calcium in channel receptors. Or in hormones, you know, it's the hormone binding protein in the cytoplasm. But we don't care so much about it because we only work with these 2 receptors. So that's the second messenger. And the third messenger is always an enzyme. And it can be a kinase or a phosphatase. So this would be the third messenger here. The kinase is the one that activates the substrate by giving the phosphate away. And the phosphatase, it takes the phosphate out, so it inactivates the substrate. So that's what these messengers mean. Now, lithium also prevents apoptosis by inhibiting this glycogen synthase kinase. So this is an enzyme, and if it's a kinase, so that means it's a third messenger, right? It's the one that gives away the phosphate. And this enzyme is a very bad enzyme for psychiatrists because it causes apoptosis and death of cells. But in neurons, the cells don't really die, but we have something called localized apoptosis in which the dendrites die. But in some situations, this enzyme can be actually a good guy because it induces apoptosis. You know, so think of the cancer cells. You know, we want cancer cells to die. So the oncologists, they are working on drugs that activate the GSK, and we are working on drugs that decrease the GSK. Hopefully, cancer will not be a side effect. Hopefully. And also lithium increases serotonergic transmission. Okay, so both lithium and valproate are neuroprotective. So what does it mean? Well, it saves the dendrites. Most of our brain is made of dendrites, and dendrites grow, but they also can be destroyed. Dendrites put out something called dendritic spines, which form connections or synapses. So each dendritic spine can turn into a dendrite. So the pro-apoptotic factors, or GSK3, destroys these dendrites and the number of synapses. And the anti-apoptotic factors, like BDNF, increases the number of dendrites and the number of connections. So novel GSK3 inhibitors are currently being developed, well, people believe that they will be efficacious in mania. Now, what about the anticonvulsants? Well, basically there's two classes, the sodium channel blockers and the calcium channel blockers. Again, these calcium channel blockers are not the ones that verapamil or nifedipine works on. These are calcium channel blockers that are situated in the synapse itself. Okay? So sodium channels are on the axon, on the side of the axon, and calcium channels are in the synapse. So calcium channels are a little bit more complex because they break the vesicle with the neurotransmitter and cause the spilling of neurotransmitter. So these are the sodium channels. Okay, so who binds here? Well, almost all the anti-epileptic drugs bind on sodium channel except neurontin and pregabalin. And sodium channels are simpler. They are made of two units, alpha and beta. And this is what Tegretol and oxcarbazepine binds. Okay? Now, calcium channels are a little bit more complex. They are made of more proteins. But the one that we care about is this alpha-2 delta. Okay? Because these medications like neurontin and pregabalin, Lyrica, they are called alpha-2 delta ligands because this is what they bind. They bind on this protein here. Okay? So only these two anti-epileptics work on calcium channels. Now, FDA indication for anticonvulsants, the Valtorex ER in acute mania, maintenance treatment of bipolar disorder. In maintenance, it's actually the Valtorex, it's not the ER, and migraine prophylaxis. Lamotrigine, Lamictal, maintenance treatment of bipolar 1 disorder. That may surprise us because we think of Lamictal as an antidepressant and a medication that may be used in bipolar depressed. But actually it has the FDA indication for the maintenance of bipolar 1. And carbamazepine ER has the indication for mania. The Valtorex in acute mania, efficacy up to 70%, quicker onset of action in 3 to 10 days. And predictors of response, it has comparable efficacy in mixed and rapid cyclic. So remember, lithium was more for like initial episodes of mania, and the Valtorex is more for later on in the disease, and rapid cyclic. Now the side effects and toxicology of valproate. Well, here are the good news first. Several studies indicate that valproate reduces total cholesterol, low-density lipoproteins and high-density lipoproteins, and protects against the adverse effects of some antipsychotic drugs on liver function. So this study here, done in 2003, showed that valproate, used as an adjunct of olanzapine and risperidone, lowered the cholesterol level in patients with schizophrenia and schizoaffective disorder. So that's a good thing. And also remember that it's neuroprotective. Improves cognition. This study done in 2000 showed that valproate caused improvement in short-term verbal memory. Pancreatitis, there's a lot of talk about pancreatitis, and valproate is associated with infrequent acute pancreatitis. But in 3 migraine trials, the rates of elevation of amylase were similar between valproate and placebo groups, and this study was done in 2002. Now, these studies show that the precautionary amylase level provide little benefit in predicting pancreatitis. psychiatrists. For this reason, psychiatrists should be guided by the clinical symptoms. So does that mean that we shouldn't determine the amylase? No. It just means that we are still treating the patient and not the laboratory values. So, but the clinical picture seems to be more important in detecting pancreatitis than the enzymes. Hepatotoxicity, usually limited to patients, very young patients. Actually, a study done in 2000 on 187 patients showed improvement in laboratory indices for hepatic function, and of course, no hepatotoxicity. And another study in 2003 had similar results. So the risk for hepatotoxicity is mostly when Depakote is used with carbamazepine, with Tegretol, because Tegretol does not have a protective action. Now these are the bad news. GI effects, tremors, sedation, hair loss. Hair loss is due to the chelation of trace metals in the intestines, like selenium and others. Weight gain, 3-4 pounds weight gain is seen in about 3 to 29% of patients. Polycystic ovarian syndrome, 4 to 12% of women, but appears more frequent in women with epilepsy for some reason. Here's lamotrigine, Lamictal, used as monotherapy in bipolar mania. Remember, it has the approval for maintenance treatment of bipolar 1 disorder. And lamotrigine also has been studied as maintenance monotherapy in bipolar 2 disorder, but the data is not there yet to prove that. 41% of patients treated with lamotrigine versus 26% of placebo patients were stable without relapse for about 6 months. Special considerations, as you know, when given together with Depakote, the dose of Lamictal has to be lowered. Now this about Tegretol and Trileptal, oxcarbazepine, liscarbazepine. What's liscarbazepine? Well, the Trileptal is a prodrug, which means it's an inactive substance, but it becomes active in the intestine when metabolized. And it turns into liscarbazepine, or the S enantiomer. So guess what? The industry is now making a drug called liscarbazepine, just using the active component. And again, when Lamictal works, it's on the sodium channels. Carbamazepine indications, side effects, and drug-drug interactions. Well, carbamazepine and oxcarbazepine have no FDA indication for bipolar disorder. But in 2004, the FDA approved carbamazepine ER under market name of Equetro for the treatment of acute manic and mixed episodes. Adverse effects, there's a black box warning regarding aplastic anemia. It's 16 per 1 million patients per year, which means that if 1 million patients took these medications for 1 year, 16 will develop aplastic anemia. For agranulocytosis, that number is about 48. And then don't forget about the drug-drug interaction with Tegretol. It works, it's an enzyme inducer of 3A3 and 3A4. 3A4 is the enzyme that metabolizes most of the atypical antipsychotics. So what Tegretol does is decreases its own level by autoinduction and decreases the level of the atypical antipsychotics mostly. I think last time I mentioned that in test exams, many times they mention this, they give you a scenario saying that this patient with schizophrenia on 6 milligrams of Risperdal treated for 1 year, the patient was stable, Tegretol was added, and the patient decompensated. So this is what they want you to say. It's because of the enzyme induction of 3A4. Okay, this is an interesting topic. It's a newer topic now. that anti-epileptic medications cause folate deficiency. And even newer is that they also cause vitamin D deficiency. So even the data beginning to emerge that even the newer anticonvulsants like valproate may deplete the folate. How do we measure that? We measure by homocysteine levels. And why? It's because folate, remember, folate does not cross the blood-brain barrier. It has to be transformed into L-methyl tetrahydrofolate. Okay? So it has to be methylated. So when the methylation happens, homocysteine will go down because it's the system homocysteine methionine which gives the methyl. Okay? So many people now in like newer papers, they recommend using diplin. Diplin is L-methyl tetrahydrofolate. So it's the one that crosses the blood-brain barrier. So they recommend using diplin in people who are on anti-epileptic medication. Atypical antipsychotics, we already know, they work on D2, block dopamine, and they also reduce glutamate hyperactivity via 5-HT2A blockade. Well, from the old antipsychotics, chlorpromazine is the only one that has the FDA approval for bipolar disorder, for manic type of manic depressive illness. It also has the approval for combativeness, explosive hyperexcitable behavior in children, and psychosis. So I know many times in manic patients we tend to give Haldol, but if you want to have the FDA backing, then Thorazine is a better choice. Other agents, memantine, amantadine, and ketamine, they work in a similar way. See, this is memantine, amantadine, and ketamine. So they basically block the L-methyl D-aspartate receptors. Memantine can be thought of as an anti-magnesium drug because the magnesium blocks this channel of the N-methyl D-aspartate here. And in order for the calcium to go in, magnesium has to be removed. Well, memantine acts like a cork, so it keeps magnesium in place. So it does not open the receptor, so the calcium cannot go in. And amantadine is similar. It's an anti-magnesium drug, but it also stimulates the dopamine, so increases the dopamine. And ketamine, you know that it's being used now as an IV drug for major depressive disorder and bipolar disorder depressed. The mechanism of action is the same. It blocks the N-methyl D-aspartate, but it blocks it right here, inside the canal. So it binds right where the PCT site is. Now these are the combinations because there's no such a thing as an ideal mood stabilizers. We use these combinations. So any atypical methyl combination, any atypical Depakote combination that we always use, and olanzapine, fluoxetine, Symbiox, it has actually the FDA approval for maintenance. Now these are the adjunct medications that don't work for bipolar itself, but they can be used to treat anxiety or weight loss or sleep. And they are gabapentin and pregabalin, Topamax, zonisamide. Zonisamide also causes weight loss like Topamax. And then tiagabine, pregabalin, and gabapentin can be used for sleep. Now what about mood destabilizers? Is there such a thing as a mood destabilizer? Well, many psychotropic medications and non-psychotropic drugs affect the mood. Like for instance, we know that isoniazid can cause mania. That's how it was discovered that it's an antidepressant. Prednisone can cause mania, psychosis, can cause depression. Acyclovir can cause psychosis. Hydroxychloroquine, psychosis, mania, depression, anxiety. interleukin, quinolones, even cephalosporins. Since cephalosporins can cause euphoria, and clarithromycin. So where it becomes important, it's really not that important in our patients if they are treated with, let's say, cephalosporin for a week or so. You know, they will probably not decompensate. But what this is important is in HIV patients because they get longer treatments with these medications. And then some of the drug-drug interactions, isoniazid increases haloperidol and tegretol levels. Quinolones increase clozapine level and benzodiazepine level. Erythromycin and clarithromycin can increase buspar level, but we don't care that much about buspar, but they increase clozapine level, so they may cause seizures. Now, are antidepressants mood destabilizers? Well, nobody knows for sure, but the opinions are being divided in this country. And here on the West Coast, we are more lenient with this kind of combinations, and we give bipolar depressed patients antidepressants. But on the wrong coast, they don't. They are very strict about it, and for any diagnosis of bipolar disorder or schizoaffective bipolar type, they do not prescribe antidepressants. Well, let's look at the data. What does the data say? Well, it is true that bipolar patients spend much more time in depressed phase than in the manic phase. Okay? Antidepressants may be effective for bipolar depression. But not everyone agrees about when or if or how the antidepressant should be used. This is a study that was done in 2007 to clarify this issue. And it's part of the STEP-BP study, Systematic Treatment Enhancement Program for Bipolar Disorder. It's an NIMH study. And it showed that 23% of patients with bipolar depression treated with an antidepressant in combination with a mood stabilizer achieved euthymia for at least 8 consecutive weeks. So that should give us, you know, that may make us think that it's good to use an antidepressant. But look at this. 27% of patients who had placebo added to a mood stabilizer also achieved euthymia. So, and other large studies confirmed this finding. So looks like it's not a good idea to use an antidepressant in bipolar mania. And there's risk of rapid cycling, switch to mania in depressed patients. So it's a slippery slope. It's something like this, you know, a fine line. And these are the future antipsychotic and mood stabilizing medications. We already talked about liscarbazepine. It's the active ingredient in trileptal. JPZ4 is a compound which is very similar to lamotrigine. And then we talked about GSK3 inhibitors. That they are in clinical trials. Now, I believe they are in phase 3. So the fear here is that they will not cause cancer as a side effect. Glucocorticoid antagonists, mifepristone or the abortion pill, RU486, is in phase 3. Corticotropin releasing hormone and vasopressor antagonists. Neurokinin 1, neurokinin 2. Neurokinin 2 is further in the clinical trials than all the other neurokinins. And then the acetylcholine linked agents like varenicline, which is used for smoking cessation and binds on alpha-4 beta-2, and ispronicline, which binds to alpha-7, are being tried. Glycine. This is glycine transport inhibitors. They are also used because they prevent the uptake of glycine by the N-methyldeaspartate receptors. And, you know, basically do the same thing that memantine or amantadine does. And that's about it. Any questions, comments? Anybody? one question.
Is there any thought that, why do they think that metabolite will serve as a mood stabilizer when the drug is the inherent drug is questionable?
Correct. Yeah, I agree with you. It's something that is being tried now. It's a drug that they are using. It's now in clinical trials. So see if the active ingredient of trilactone would make a difference because you can use higher doses. Yes? Ox capacity, that's a trilactone. The least capacity is going to be a better yes, because it's absorbed right away and it doesn't have to undergo activation by the intestinal enzymes. Yes. Anybody else? Okay, thank you. Thank you.